In this scenario, I'm going to use a channelless video laryngoscopy blade, a video called the King Vision. With this device, I'm going to show you how I would preferably use gastric diversion. So in this patient again, similar scenario, there's a need for deemed necessary for intubation, pre-oxygenated with high flow oxygen, 15 liters per minute, high flow, 15 liters per nasal cannula, a lot of hissing in the room. The patient's already gotten his medications through IV, ketamine and rock, accommodating sucks, whatever floats your boat, whatever is not contraindicated, whatever you're comfortable with. This is channelless, and because this is channelless, I would recommend, whereas the other technique didn't require a stylet through an ET tube, the 6.5 or 6.0 ET tube, I'm going to recommend a stylet to guide the tube into the esophagus to make sure you goose the patient for gastric diversion. So insert the mouth, blade in the mouth. Patient has desatted yet. Take the 6.5 or 6.0 ET tube and make sure I boost the airway, the esophagus. Pull it back. Inflate 10 cc's. I can worry about what's coming out, but I'll divert that to the same tubing we would use to a Yan collar. Passive regurgitation can happen now, but I'm comfortable now that anything that comes up will be diverted out. Hopefully the patient hasn't desatted yet. I'll take an ET tube, 7.5 ET tube, use the same stylet. I won't take out my channelless radio laryngoscopy device. This could possibly be used the same way as the Glidescope. Guide the tube in, pass the cords, disengage the stylet, advance it deeper. Now I'll have to inflate this cuff, the 7.5 ET tube. Now I have to confirm with chest rise, misting, and all the usual things like entitled CO2 of a correct placement. Start bagging. I find that if I kept the blade in and didn't disengage it, I could still get the intubation in. Will the tube that's already in there, this ET tube that's acting as a gastric tube, impede my view? Perhaps, but that's why I'm using video laryngoscopy. Could this technique be used with direct laryngoscopy? Yes, it can. But we're in the 21st century, so I'm trying to show you some 21st century techniques. I will show videos with direct laryngoscopy in the near future, most likely with a Glidescope titanium T3 blade that mimics a Mac blade. Alright? Any questions? Thank you.